Hello, my name is Rachel, and today I'm going to be presenting this case-based discussion on cough. I won't run through this all now, but this is what we'll be looking at today. Starting with our demographics and presenting complaint. So, Mr. B is a 50-year-old male. He presented to his GP practice following a 3-week history of cough. He is Caucasian, and this is obviously in a primary care setting. History of presenting complaint. When asked about his cough, Mr. B did state that it was a productive cough. He's been bringing up green sputum that is particularly foul in both odour and taste. He described it as being something that tastes really horrible and unpleasant. It is quite thick, viscous, and really not very nice for him. This has been going on for 3 weeks. It is not deteriorating or getting better. It's stable without change. When asked, he denied any hemoptysis. He has been febrile. He described feeling quite hot, cold, sweaty, and he also described night sweats. Mr. B complained of right shoulder pain. This has been going on for the previous week, not the full 3 weeks. He described it as sharp and constantly there, but worse on inspiration. It sounded very muscular in origin. He is short of breath, but able to walk 100 meters or so without issue. He is quite fatigued and has said that this is really impacting him at the moment. I'm very tired, very lethargic. He's lost his appetite, but he's not lost any weight. And he described the whole situation as a bit shit, but then voluntarily denied being depressed. He denied any symptoms from system review. I will be looking at past medical history. For the patient's past medical history, the patient did report uninvestigated seizures. The patient explained this by moving his arms and body and demonstrated quite a typical tonic-clonic style seizure. The patient stated that he does go to A&E when these happen, but he gets very frustrated with waiting around. Felt that he's not really being treated well and self-discharges before treatment. He said he was meant to see a neurologist, but he doesn't like waiting in the hospitals. Patient did also report that he may have had ADHD as a child, but this is unknown. With the uninvestigated seizures, the patient reported that he'd been having these quite a while, but they're not frequent. The patient's mother is a known asthmatic, and the patient's father has hypertension. He has had no current contact with either of them for the last few years, and this may affect an up-to-date family history. Now we'll be looking at drug history, allergies, social history, and ICE. The patient is not on any current medication and has no known allergies. The patient did report that he had previously taken metazapine, although he seemed unsure what the indication for this was. Metazapine is typically only indicated in major depression, but the patient did not have any awareness of this. Socially, the patient has been homeless for approximately 5 years. He self-reported that he sleeps in a car park and spends his days He's sitting in the front of Sainsbury's, and he is there with a few other homeless friends. He is a current smoker. He's smoked 20 cigarettes per day for the past 30 years. He smokes cannabis. The patient has approximately 4 to 5 spliffs a day for 3 years. And there appears to be a strong emotional dependence on the cannabis, as the patient reported that they help him get through the day and deal with his current circumstances. Additionally, the patient drinks approximately 8 cans of strong cider when available, which is most days. A conversation was had with the patient about whether they would be interested in working with alcohol use services and drug services, and the patient was amenable to this and would be agreeable to working with these services. Before he was made redundant 5 years ago, the patient was a truck driver. In terms of ICE, the patient was very insistent that he needed antibiotics. He seemed to believe that antibiotics would clear his chest, and he just wanted to get rid of this shit, referring to the sputum. When asked again if he had any other concerns or ideas, patient just repeatedly said about antibiotics. A conversation was had with him at this point, just briefly to mention and explain that antibiotics may not be the most appropriate action, and that's something we would address later on, which seemed to calm the patient down. We'll now be looking at the examination findings and investigations. On examination, the patient had a temperature of 37.8 degrees Celsius. His blood pressure was 120/80 millimeters of mercury. His pulse was 106 beats per minute. His resp rate was 24. On auscultation, there were crackles and decreased breath sounds over the base of the right lung. Generally, there is evidence of gingivitis and dental caries. He has bilateral athlete's foot. He generally looked quite unkempt. Throughout, he appeared agitated, but he did settle towards the end. To further expand on this, I would have O2 saturations, peak flow, general weight, chest X-ray, C-reactive protein, and possibly microbial sputum sample. Further examinations, I would do a mental state exam to assess his mood, and also I would also have him complete an alcohol use disorders identification test. Moving on to differential diagnoses. So we have 3 differential diagnoses, and I have put them here in order of most likely to least likely. Most likely, I believe, is community-acquired pneumonia. Community-acquired pneumonia is an infection of the alveoli of the lungs. I believe this is the most likely differential due to the patient's presentation, and especially the decreased breath sounds over the right base. The decreased breath sounds are indicative of some sort of fluid, and I believe it is most likely infection there, and the crackles heard on auscultation also support this. Community-acquired pneumonia is often bacterial, and I would say that his dental hygiene with the gingivitis and the dental caries are a risk factor for infections. Infections generally, but specifically here looking at a lung infection. Slightly below this would be acute bronchitis. Acute bronchitis is an inflammation in the airways of the lungs caused, again, usually by infection. This is my second differential diagnosis, but it wouldn't explain the decreased breath sounds with crackles in one area of the lung. I do feel that the mucus sputum that the patient reports would support this diagnosis, and acute bronchitis can last up to 3 weeks, which is the time frame that we're looking at with Mr. B. However, with acute bronchitis, patients don't always get a fever. Occasionally they do, and it's generally less severe symptoms than seen in community-acquired pneumonia, and I really feel that we're looking at CAP. Thirdly, on my differential diagnosis is tuberculosis. Now, tuberculosis is an infection that primarily affects the lungs. I feel this is a candidate as a diagnosis because of the patient's reported night sweats and general presentation. I think one big risk factor that we need to highlight is that the patient is homeless, and tuberculosis is not uncommon in areas that have high levels of homelessness, and also sort of chance of transmission, or the risk of transmission increases when sharing spaces in these communities. I think it is a very important diagnosis to rule out because the treatment is so intensive and different to that of community-acquired pneumonia. So having a closer look at community-acquired pneumonia, it is inflammation of the alveoli secondary to infection. This is usually strep pneumoniae or Haemophilus influenzae. Symptoms can include cough, fatigue, fever, shortness of breath, mucus production, all symptoms that Mr. B currently has. Here we have just a diagram of healthy alveoli versus pneumonia-filled alveoli. As per NICE guidelines, further investigations are warranted. I briefly discussed these further investigations earlier. Chest X-ray is really important in diagnosing community-acquired pneumonia, as that's quite a sensitive test to show areas of consolidation in the lung. C-reactive protein is on the NICE guidelines, which, whilst it's a fairly non-specific test, it will show if it's elevated, levels of inflammation and potential infection. Sputum samples may be sent off for microbial testing and see what, if anything, can be cultured. For moderate to severe cases of community-acquired pneumonia, admission to a hospital is usually indicated relatively immediately. This may be oxygen sats below 94, maybe 90. This may be evidence of tiring from labour breathing. For low severity community-acquired pneumonias, these can often be treated in the community setting. Treatment will typically be antimicrobial, as you can see on the right hand side here. I shan't read out the entire list, but you can see for each level of severity and whether or not someone has a penicillin allergy or other contraindication that dictates the choice of drug or drugs. In a patient with low severity community-acquired pneumonia, the first line of treatment is amoxicillin. If they have a penicillin allergy, it will be one of the three: doxycycline, clarithromycin, or erythromycin. In moderate or severe cases of CAP, oxygen may be indicated, as well as that a higher level of support in hospital, as just mentioned. Mr. B's presentation of would indicate admission to a hospital, I would say. His respirator is 24, which is higher than we'd like. He has a high temp, and he's tachycardic. I would be worried here that this is a more severe illness, or sort of the start of potential sepsis. This is certainly something we'd like to rule out. Another way of assessing whether a patient should be admitted to hospital for CAP is using the CURB-65, which is a screening tool for potential mortality in pneumonias. Mr. B did not score highly on the CURB-65, but because of the other factors mentioned, I feel he would be best treated in a hospital setting. To summarize, Mr. B is a 50-year-old male who has presented with a cough. Throughout the history, it seemed to be a rather productive cough, which has been causing him a great deal of distress. On examination, he is tachycardic, a high respirator and a high temp, and this would indicate that there is an infection going on. Based on the history and examination, I think it would be likely to say that he has community-acquired pneumonia, although I would like to rule out tuberculosis. The best way forward, I think, would be admission to hospital where he can receive more supportive treatment, the appropriate antimicrobials, and oxygen if he is required. Thank you very much for listening. And then here are the references of the NICE guidelines used.